treating critically ill patients with acute kidney injury, those who need dialysis. It's just such a constant tightrope walk, isn't it?
Oh, absolutely. You're trying to support the kidneys with RRT, renal replacement therapy, but the treatment itself can really destabilize them.
Especially their blood pressure. Yeah, it could
Yeah.
just throw everything off.
Exactly. And, in those moments, the reflex is often to reach for vasopressors to keep that pressure up.
Right.
But that leads to a really crucial question, doesn't it? For anyone looking after these patients, I mean. What happens when we have to use these drugs after starting the RRT? Does that tell us something important about their chances?
That's exactly where we're headed in this deep dive. We're digging into this really interesting paper. It's called Association of Vasopressor Use During Renal Replacement Therapy and Mortality, published in the Journal of Critical Care.
Mm-hmm.
Think of this as, your quick route to the main insights, the stuff you really need to know if you're following critical care without getting totally bogged down in all the technical details.
Yeah, our goal here is pretty straightforward. We want to unpack what this research found about that link, the connection between using vasopressors after RRT starts, and, well, whether patients survive their hospital stay.
Which is absolutely key information for critical care clinicians dealing with these, incredibly complex cases.
Definitely.
And maybe before we jump right in, it's worth quickly mentioning the two main RRT types they looked at, because the findings apply to both.
Good point. Yeah, they focus on continuous renal replacement therapy, CRRT, that's the slower continuous dialysis,
Right.
and intermittent hemodialysis, or IHD, which is the more periodic, shorter sessions.
Okay, got it. So let's unpack this then for the critical care docs listening. What was the absolute core question? What were the researchers really trying to figure out here?
Right. So for the clinicians tuning in, the main thing they wanted to know was, if a patient needs vasopressors after we've already started them on RRT, does that predict anything? Specifically, is it linked to their chances of dying in the hospital?
And that's whether it was CRT or IHD?
Exactly. And the emphasis was really on the after part. Not so much the pressors used before dialysis started, but what happens once it's running.
Okay, so that's the question. How did they actually go about answering it? What kind of approach did they take? What data were they looking at?
Well, it was a big observational study. They tapped into a major U.S. hospital database, the Premier Inc. AI healthcare database, PINC AI, they call it.
Okay.
And this gave them data on, get this, over 20,000 adult patients, all with AKI needing RRT.
Wow. Okay, 20,000. That's a serious number of patients. And what sort of time frame are we talking about for this data?
They looked at data from January 2018 through to June 2021. And importantly, they focused specifically on patients where CRT or IHD was the first type of RRT they got in the ICU.
Right, so they could compare those two main methods directly.
Precisely.
And for us clinicians, how do they actually track the vasopressor use? That seems like a critical piece here.
Yeah, it really is. They looked at vasopressor use in two windows. The 3 days before RRT started, and then, crucially, the 3 days after it started.
Ah, okay, so that post-RRT window was the main focus.
Exactly. They wanted to see if starting or continuing pressors in those first few days of dialysis correlated with mortality.
Were there certain patients they left out? As practitioners, we always want to know who wasn't in the study.
Yes, absolutely. Good question. They had some key exclusion criteria. So, no patients with pre-existing end-stage renal disease, no prior kidney transplants,
Okay.
and no one whose first RT was something else like peritoneal dialysis or maybe SLED, the sustained low-efficiency dialysis. It had to be CRT or IHD first.
Makes sense. Keep the groups clean.
Right. And also, patients had to survive and be in the hospital for at least 3 days after starting RRT.
Why was that?
Well, so they could actually assess the vasopressor use in that early post-RRT phase properly, and they also needed complete data on IV fluids.
Ah, okay. To get a sense of the overall hemodynamic support picture. Got it. So with all this data, how did they actually crunch the numbers? What stats did they use to see if there was a real link?
They used a technique called multivariable Cox regression. It's pretty standard for this kind of survival analysis.
Right, that lets you adjust for other things that might affect mortality.
Exactly. It allowed them to look at the impact of vasopressors while controlling for a whole bunch of other factors. Things like, patient age, sex, ethnicity, their other health problems, comorbidities, how sick they were overall. These severity scores looked at sepsis, COVID-19 status, things like that. Also, mechanical ventilation, ECMO use, and, as we mentioned, the amount of IV fluids given before and after RRT.
Wow, okay. So thinking about our own patients, they really tried hard to isolate the specific effect of needing those pressors after RRT started.
That was the goal, yeah. And the analysis specifically looked at two things about post-RRT vasopressor use. First, just yes or no, did the patient get any vasopressors? And second, how many different vasopressors did they need? They grouped them as 1, 2, or 3 or more.
Ah, so looking for like a dose effect?
Precisely. To see if needing more support meant higher risk.
Okay, so they did all this work, controlled for all these factors. What did they actually find? What are the key results that, critical care physicians should really pay attention to?
Right, this is where it gets really interesting for clinical practice. The main finding was pretty clear-cut. Needing vasopressors in those first 3 days after starting RRT was significantly linked to a higher risk of dying in the hospital.
Okay, significantly linked.
Yes. And this was true for both the CRRT patients and the IHD patients. The adjusted hazard ratios, the measure of risk, were pretty similar, actually, about 1.69 for CRRT and 1.72 for IHD.
So roughly a 70% increased risk associated with needing pressors post-RRT, regardless of the dialysis type.
That's right. It suggests that needing that support after dialysis starts is, well, it's a bad sign, whichever way you slice it initially.
That's a pretty stark finding.
Yep.
But you mentioned they looked at the number of pressors, too. Did that show anything?
Yes, and this is, I think, a really crucial point, a kind of aha moment. They found a clear dose-response relationship. Meaning the more different vasopressors a patient needed after starting RRT, the higher their risk of death.
Okay, wow. Could you give us the numbers on that?
Sure. For the CRRT group, needing one pressor had an adjusted hazard ratio of 1.50. Needing 2 jumped it to 1.94, and needing 3 or more pushed it to 2.06.
So more than double the risk for 3 or more compared to none.
Exactly. And the trend was similar, maybe even a bit steeper for the IHD patients. One pressor was 1.57, 2 pressors shot up to 2.tween, and 3 or more was 2.32.
Goodness. So it really emphasizes that it's not just if you need support, but the level of support required seems directly tied to mortality risk.
Precisely. It's about the intensity of that hemodynamic instability.
Were there any other findings that jumped out, maybe about specific drug combinations or anything else we should note?
Yeah, they did a secondary analysis looking at common combinations. It wasn't all statistically significant, but the most common combo, they saw norepinephrine plus vasopressin.
Which we use all the time.
Right. That combination was also linked to a higher mortality risk compared to just using one vasopressor, so that's relevant for daily practice.
Definitely. What about needing pressors before RRT? Did that matter in the end?
Interestingly, no. In their adjusted models, needing vasopressors before starting RRT didn't independently predict in-hospital mortality.
Huh. So it really zeroes in on that period after dialysis starts.
It seems to, yeah. It really highlights the importance of the hemodynamic course once RRT is actually underway.
Any other observations, maybe about fluids or differences between the CRT and IHD groups?
Well, they did note that patients needing post-RRT vasopressors also tended to need more IV fluids after starting RRT.
Okay, suggesting ongoing instability or maybe fluid balance challenges.
Could be. And regarding the groups, they found, maybe not surprisingly, that a higher percentage of CRRT patients needed pressors after starting.
Which makes sense, right? We often use CRT for the less stable patients to begin with.
Exactly. But here's an interesting twist. The IHD group seemed to be more impacted by needing multiple vasopressors. Their mortality risk climbed more steeply with each additional pressor.
Oh. What might that suggest?
Well, maybe it suggests that patients who were initially deemed stable enough for IHD are just less tolerant of the kind of severe instability that requires piling on multiple vasopressors.
Yeah, that's a really interesting point to consider clinically. Okay, so we have this clear link. Needing pressors after RRT starts, especially multiple ones, is associated with higher mortality. For us in critical care, what were the main conclusions the researchers drew from all this? How did they interpret these findings?
Well, their main conclusion, the one they really stress, is that vasopressor use in those first 3 days after starting RRT is independently associated with higher in-hospital death rates. And it's incremental, more pressors, more risk. And it applies to both CRT and IHD.
Okay. And did they speculate on why? What were the potential explanations they discussed?
They offered a few possibilities. One, and maybe the most likely, is that needing vasopressors post-RRT is simply a marker. It reflects that the patient is just sicker, more hemodynamically unstable to begin with.
Right, the pressors aren't the cause, but a sign of the severity.
Exactly. Another idea is maybe some patients become less responsive, kind of insensitive to vasopressors, leading to ongoing low blood pressure and organ damage despite the drugs. And they also briefly mentioned a less common idea, the possibility that the RRT circuit itself could actually be clearing some of the vasopressors, especially if the infusion line and the dialysis catheter are close together.
Oh, that's an interesting technical point about line placement potentially.
Yeah, something to maybe keep in the back of your mind.
Yeah.
They also circled back to that difference between CRT and IHD. The higher use in CRT, but maybe bigger impact in IHD, suggesting again that maybe those IHD patients just don't handle that level of instability as well.
Makes sense, given the nature of IHD with its bigger fluid shifts, perhaps. Now, of course, we always have to consider the limitations. What did the researchers themselves point out?
Yeah, they were upfront about that. It's an observational study, so you can't prove cause and effect. Needing pressors might just be a sign of being sicker, like we said.
Right, correlation isn't causation.
Exactly. Also, they only looked at the first 3 days post-RT. We don't know about longer-term use. And they didn't have data on the actual doses of vasopressors or how they were adjusted.
Ah, okay, so no dose details, just the number of agents.
Right. And finally, they had to exclude patients who died really quickly after starting RRT within the first couple of days. So potentially, the absolute sickest patients might not be fully represented.
That's an important caveat. But despite those limitations, the study had real strengths too, didn't it?
Oh, absolutely. The huge sample size for many different hospitals, diverse patient population, that's a major strength. And the fact they use that multivariable analysis to adjust for so many potential confounders really adds weight to the findings.
Okay, so as we sort of wrap up this deep dive, what's the absolute key message? What should critical care doctors really take away from this research for their practice?
I think the crucial takeaway is this. Needing vasopressors, and especially needing multiple vasopressors, in those first few days after you start a patient on RRT, well, it's a really strong signal of increased mortality risk.
And that holds true whether you started them on CRT or IHD.
Yes, the association was clear for both modalities.
But, and this is important for how we think about it clinically, it doesn't necessarily mean the vasopressors cause the death, right?
Exactly. It's much more likely reflecting the severity of the patient's underlying illness and their persistent hemodynamic instability. It's a marker, a really significant one, but probably not the direct cause in most cases.
Okay. So as we finish up, what's maybe a key question or a provocative thought this raises for clinicians listening? Something to mull over.
I think this really pushes us to ask, how does this impact how we monitor and manage hemodynamics during RRT? Should we be thinking differently about our fluid strategies or vasopressor thresholds, maybe even our choice of modality, especially if an IHD patient starts needing more and more pressor support? Does that signal a need to switch gears?
Yeah, definitely food for thought. How sensitive should we be to that escalating need, particularly in the IHD group?
Exactly.
Well, that's certainly something for all of us in critical care to consider. And for those listening, I'd really encourage you to maybe reflect on how this info might inform your practice, and perhaps check out the original paper if you want even more detail.
Yeah, it just highlights how complex this area is, doesn't it? The interplay between kidney support and hemodynamics. It's critical, and we're always learning more. Studies like this really help us refine how we approach these incredibly challenging patients.